Good day, everybody. I'm Chamath from the Department of Family Medicine. I hope you're all doing well during the pandemic. And I thought of doing this basic introductory video on palliative care uh, while I'm still on study leave. Um, so this is mainly aimed at medical students, but uh, also the healthcare students can gain whatever the knowledge they require from this session. And it might be slightly a lengthier video as for a lecture. So I would suggest you to get yourself a cup of coffee or tea and join me for the rest of the session. And I hope to segment the video as I upload it onto the YouTube so that you can reach whatever the segment uh, you need to learn more about um, as you watch the video. So let's start. So starting on with the objectives of this session, we will understand what the palliative approach to care is, and we will understand the range of diseases that could be helped with palliative approach to care. And then we will learn a little bit about the history of uh, the discipline, how it evolved and all that. And then we will identify the need for palliative care along the course of different terminal illnesses. We will come to this soon. And then we will appreciate the differences in varying terminal illness trajectories. Then we will understand the symptom burden associated with different life-limiting illnesses, and including the emergencies in palliative care that we have to face. Then we will identify the roles of different personnel involved with palliative care provision. Then we will try to identify the institutions and settings where palliative care is provided uh, in the global context as well as in the Sri Lankan context, what these institutions are. And then we will understand how decision making can be made easier in terms of patients who have lost mental capacity. So to start with, you will also need to know a little bit about mental capacity to be able to learn that part. So etymologically, the term palliative has derived from the medieval Latin term called pallium. Pallium or palliar is to cloak or to cover. So you need to understand that. So with this, akin to the origin of this word palliative, it means that we are aiming to cover, cloak, so many aspects of a patient when we treat patients through palliative care. So we are not going to stick to just one aspect as we do with many other clinical disciplines, but we are going to cover so many aspects. So this is an all-encompassing, broad form of a clinical discipline. We will move on to the definition of palliative care. So this is the definition by the World Health Organization. Palliative care is an approach that aims to improve the quality of life of patients and their families facing the problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification, impeccable assessment, and treatment of pain and other problems, physical, psychosocial, and spiritual. So we will go through each element of this definition in the next slide, and it is important that we are, rather than just having this definition by heart, it is important for you to be pondering each aspect of this definition, to be very thorough with them. So through the extended definition, the WHO goes on to explain what palliative care really is. Here we are dealing with patients diagnosed with chronic life-limiting illnesses. So earlier we also used the term terminal illnesses, but the literature has, the research has found out the word terminal can be a bit too sensitive to the patients and their families. So instead we use the term life-limiting illnesses. So these patients tend to have a range of symptoms. Some of them are physical. So through the palliative approach to care, we aim to relieve pain and other distressing symptoms. So before we go about alleviating the symptoms, we need to know more about the symptoms. So initially, we identify that certain symptoms are bothering the patients. That's number one. And then we do an impeccable assessment of the extent to which the symptom is present in the patient, or the extent to which the patient is burdened by specific symptoms. And then we move about, we resort to manage the symptoms afterwards. So another problem associated with life-limiting illnesses is that the patients and the families tend to be more worried about death than in other illnesses. So death is an inevitable eventuality. We all cannot escape death, but then we need to identify, we need to acknowledge that death is a natural process. So we are doing that in palliative care. So we are accepting death, and in anticipation of dying and death, we have to do certain things beforehand. So that consciousness about death might be of some use in palliative care. So when we do the treatments, when we treat the patients, we are neither expecting to hasten death nor to postpone death. So, we will come to that later on, but we are not going to, bring about death by giving these treatments. So that leads to a more in-depth discussion about physician-assisted suicide and euthanasia, which are both illegal in most Asian countries, including Sri Lanka. But it is important that you get to know about the concepts behind it so that you can do your own evaluation about its appropriateness. So, and then we are no expecting to postpone death. We are not going to let the patients suffer due to extended life as well. And then, besides the management of physical symptoms, we are also identifying the potential psychological, even social and spiritual aspects of suffering, and try to help patients and their families to overcome these symptoms. So it offers a support system to help patients live actively as possible until death with the dignity they deserve. So even a patient who had lost mental capacity deserves to be, to die in a dignified manner. So we are ensuring that in delivering palliative care. So it offers a support system to the family to help the family cope during the patient's illness and in their own bereavement when the patient passes away or when the patient dies. So the family is a very significant component in palliative care. So in most other clinical disciplines, we are mainly aiming to treat the patient. But here, because of the breadth of discipline, we also include the family members, because being diagnosed with a terminal illness or a life-limiting illness invariably has effects on the family members. So it could be psychological effects, they could be social effects, spiritual concerns, and so on. So they also need forms of help. So we are helping them cope, and when the patient dies, we don't let go of the family members, but we try to help them through their bereavement. And then it is very unique of palliative care to use a team approach to address the needs of patients. We will come to that as we go further in the lecture. And then palliative care will enhance quality of life, and many research has shown palliative care to enhance the patient's quality of life. And sometimes it also have positive influences on the course of illness. We are trying to alleviate the symptoms, but at the same time, we may decide not to implement certain toxic therapies on the patients. No toxic chemotherapy, no radiotherapy, and no invasive forms of life-sustaining treatment, such as use of ventilators, use of inotropes and all that. So, alongside the improvement of quality of life, which is the main aim of palliative care, we are trying to, enhance the patient's quality of life over the quantity of life. But because we are, not implementing certain toxic therapies on the patient, as an additional advantage, the patient's life may be prolonged. So this has been shown in research studies. So there I again want to emphasize the main aim of palliative care is to improve the patient's quality of life. And then, it is a previously held opinion, even among clinicians, that palliative care, when we resort to deliver palliative care for patients, we are no longer providing any forms of treatment that aim cure. That's a wrong idea with the modern forms of literature, and the current understanding is that we can still give the patients treatment of curative intent while we have resorted for palliative care. So palliative care has to start early in the course of the patient's illness. So we will come to that in the later slides as well. So there's a new definition which came into being in 2019. So this is a consensus-based definition to which I also contributed from Sri Lanka. So the International Association for Hospice Palliative Care, or the IAHPC, brought together the experts from around the world to come into a consensus-based definition, which is shorter, but this is an alternative definition, and I personally prefer the WHO definition, but you may also go through this definition. So palliative care is the active holistic care of individuals across all ages with serious health-related suffering due to severe illnesses, and especially of those near the end of life. It aims to improve the quality of life of patients and their families and their caregivers. So a good thing that I have noticed in this definition is that it also includes the caregivers besides the patients and the family. So the caregivers include informal caregivers like maybe attendants or home caregivers, trained caregivers, and it also includes us as the clinicians, the physicians, nurses, and so on. Because we might also be burnt out caring for these patients with life-limiting illnesses. So this definition also carries the word holistic care, which includes the physical, psychosocial, and spiritual aspects. So it also gives an emphasis on the age ranges, individuals across all ages. So life-limiting illnesses are not confined to the elderly population, but it also they also affect the children. So yes, so that is that definition. And now looking at the extended definition given by the International Association for Hospice Palliative Care, you may see that they have unfolded what really palliative care encompasses, in which I have put here in point form. You may pause this slide and go through whatever they have to say about it. Okay. So, who can be benefited by the palliative care approach? So, is it only the elderly? No, we have discussed. So, it also includes children, for instance, those diagnosed with cancer, acute lymphoblastic leukemia, for instance. And then, is it only chronic progressive diseases? No. It's mostly the chronic and progressive diseases. We will give examples now, but then it also encompasses the patients in the emergency room or in intensive care units. Why is that? Because they are also, facing very critical forms of illnesses. The life-threatening element is there, and during that short period of time where the death may be imminent, we might have to do certain things proactively to enhance the quality of life of these patients. So in terms of chronic progressive diseases, you have maybe a lot of time to plan the care in a more comprehensive way, but the time limitations really are a challenge when it comes to the treatment of emergency patients and critical care patients. And then what forms of diseases? This is very important to know. What forms of diseases are suited to receive palliative care? So at its inception, mostly the palliative care was directed towards patients with cancer. So that is the most dreaded form of life-limiting illness as far as the population or the people are concerned. But there are even more severe forms of other diseases besides cancer that can lead to a tremendous amount of suffering. But cancer is what people are fearful about. So then it could be organ failure, congestive heart failure, chronic kidney disease, chronic liver cell disease, and so on. And then it could be progressive neurological diseases such as dementia, Parkinsonism, Creutzfeldt-Jakob disease that leads to progressive damage to the central nervous system, including motor neuron disease, amyotrophic lateral sclerosis, and the different forms of spinal muscular atrophy and other forms of neurological diseases. And frailty and aging. So these are two different things. Extreme age, older age could or could not be associated with frailty. There is an association, but there are people who are frail at the age of 50 when they are not old enough. So these are two interrelated terms, two interrelated concepts that you have to treat in slightly different manners. And then there are infections with a terminal cause, such as AIDS. So the patients with HIV who are on heart therapy might not be likely candidates to receive palliative care, while patients with AIDS, where the course of the disease has, flipped into a life-limiting one, may benefit from palliative care, right? And then increasingly, we have an aging global population, which also is applicable to the Sri Lankan context. So we have patients with many diseases, many non-communicable diseases, living into their older ages. So these patients are potential beneficiaries of palliative care. And then, why is palliative care this important? Why we need to pay more attention than ever before into the development of palliative care? So the global need is rising all the time. And if you would look at the top 10 global causes of death, and these data are from 2016, the leading most cause of death is ischemic heart disease, which can lead to chronic heart failure among the survivors of ischemic heart events. And then stroke, the survivors of stroke, chronic obstructive pulmonary disease, lower respiratory tract infections. It's not really a terminal illness unless there is pre-existing conditions such as COPD or obviously, or even bronchiectasis. And then we have Alzheimer's disease and other progressive neurological disorders. Then the lung cancers, trachea, bronchus, also the respiratory tract cancers are the 6th leading causes of deaths. So cancers coming to play there. And diabetes mellitus is a big part of multimorbidity, which we considered to be a part of patients who need palliative care. So diabetes mellitus is a disease that leads to very poor quality of life, and they will definitely benefit from palliative approach to care. And then the road injuries, they come way down in the in the causes of death. So the emergencies and road traffic accidents, they come lower down. So the majority of conditions that lead to death need palliative care at some point, beyond some point over the course of these illnesses. So this is an analysis of the percentage of deaths that would benefit from palliative care. So different countries, mostly these are all actually mostly European countries, and New Zealand, Canada, and US are included in this graph. So 3 different forms of research groups have carried out the need for palliative care in terms of the percentage population that would benefit from palliative care. So you could see from this graph, according to the Mertas estimate, around 70 to 85% of all patients in different countries seem to benefit from palliative care, before they face death. Now, looking a little bit back at the history, what we find on record is that Dr. Dame Cicely Maury Saunders uh, was the founder of modern palliative care. So she actually did a tremendous amount of service to the development of palliative care in the UK from 1968 to 1985. And in 1965, she defined a concept called total pain. So where she described the pain experienced by patients diagnosed, especially with cancer and other life-limiting illnesses, do not feel only physical pain, but they are also burdened by other forms of pain, social pain, psychological pain, and spiritual pain. So they are pain or even forms of suffering. So we need to look at all these aspects if we are to enhance the quality of life of these patients. We cannot just look at the physical symptoms, give some medicines to treat them, and just be happy that we've done our best. So we have more to attend to. So she, while being the founder of modern palliative care, she also established the first modern hospice in London, St. Christopher's Hospice, affiliated to King's College London in 1967. And in the UK, palliative care was accepted as a medical specialty in 1987. Now, looking at the worldwide developments, in the World Health Assembly 2014, the ethical responsibility of WHO, individual healthcare providers and governments was baked into the public health policy documents of World Health Organization. And in addition, in the Global Conference on Primary Health Care that was held in the city of Astana, Kazakhstan in 2018, palliative care was incorporated among the other 4 domains of primary health care. So the other 4 existing domains were promotive care, preventive care, curative care, and rehabilitative care. So in 2018, palliative care was incorporated among these elements or domains of primary health care. So why it is important to have this under primary health care? So primary health care is the form of healthcare that is required by all of the population, the entire population. So it is a basic human right. So patients must have access to primary health care free of charge, ideally without it incurring a cost on their pockets. So, so that is the importance of having palliative care as a part of primary health care. This is in the aim of achieving what we called universal health coverage, equitable access to health care by all who need it, when they need it. Looking at the aspects of holistic care, so this is a cornerstone of palliative care. We need to have a holistic approach to assess and treat our patients. So we have, as we discussed, it encompasses the physical aspects, psychological aspects, social aspects, and spiritual aspects. You may again pause this slide and see what each element encompasses. Only a few considerations are listed under each domain here. And yes, now we know like how Dr. Cicely Maury Saunders has worked towards the development of palliative care in the UK. But off the record, we also find similar approaches to care from South Korea and South Asia. And I'm going to give you some interesting point there. How about Sri Lanka? Do we have any evidence? I want you to go to this link that appears to the right over here. This link, and read whatever the information that is given there. You will be surprised if you have not known this earlier. So there was one Dr. Rustamji from Sri Lanka who was actually a pen pal of James Cicely Morris Saunders, and they have corresponded with each other through mails, and he had actually worked towards the early 1960s in developing palliative care in Sri Lanka. So the approach to care was very similar, and this blog post is from a UK-based website. So it is really a worth piece to read. And now we will look at a bit of terminology around palliative care. So there are different terms that people or even clinicians use around palliative care. So they sometimes use these terms interchangeably, but to be very precise, there are very there are essential differences between these terms. So one is supportive care, and another one is end-of-life care, terminal care, and palliative care. So what is supportive care is an all-encompassing term that ranges from pre-diagnosis of a form of maybe a cancer or a life-limiting illness up until the provision of bereavement care. So it is an umbrella term that includes all aspects of support that you provide as clinicians to the patients and their families. And then there is end-of-life care. So that is what you provide towards the end of life. That is maybe the 6 to 12 months, the final 6 to 12 months of a patient's life. And it generally does not involve bereavement care. And again, terminal care is when the patient is very terminal, when the patient is, we say, moribund, so that is weeks to days leading to death. So, and essentially, the goals of care are different when we move from supportive care, end-of-life care, to terminal care. And palliative care is from the point of diagnosis up until the provision of bereavement care. So that part may not be visible in this graph because I'm there right at the corner, but if you would see, it also includes bereavement care from diagnosis up until the provision of bereavement care. All right. And now, this is a very important slide. So, palliative approach to care along the course of diseases. So there are two graphs. So the first one showing what the traditional understanding of palliative care was like, and then the second model showing how proactive advanced care model for the delivery of palliative care is like. So right at this point, this is the point where the patient is being diagnosed with the life-limiting illness. And then along the trajectory of the disease, the clinicians aim to give curative treatment and life-sustaining treatment up until a certain point. And beyond that point, the palliative care is introduced, and the patient is maybe being transferred to a hospice We will discuss more about what a hospice is later on. So that is a residential care facility for patients with life-limiting illnesses. So, so it is very black and white. So either you provide curative care, or towards the end of life, you transfer the patient to a hospice where palliative care is being delivered. So this is the traditional understanding. And now what we understand is, starting from the point of diagnosis, obviously you give curative and life prolonging forms of treatment. So you try to save the patient's life, or even prolong the patient's life through the invasive or even toxic treatment modalities. But as we go along, the disease as the disease progresses, the amount of life prolonging treatment is diminishing, while the palliative approach to care is slightly advancing as we go along the disease. And it is also noteworthy that palliative care is being introduced right at the beginning, right at the point where the patient is being diagnosed with the illness, and then it slightly advances as the disease progresses. And at this point, it is basically, you have foregone, or you have stopped giving all kinds of curative treatment and life prolonging treatment, but you only give treatment to alleviate symptoms and improve quality of life of the patients through the palliative approach. And then maybe the patient could be transferred to hospice care or home care. The patients, it is known that, through the literature, we know that the patients like to be cared for in home settings. So, so the patient is being transferred home or to a hospice during this phase, and then this is the point where the patient dies. And beyond the patient's death, as we discussed earlier, the bereavement support is being offered to the bereaved relatives and family members. So that is also a duty of the palliative care clinicians or even general practitioners. Okay. Now, this is an important slide. Actually, we need to understand the illness trajectories of different illnesses if we are to care for these patients with life-limiting illnesses. All life-limiting illnesses do not assume the same course as they progress towards death, and they are essentially different. So what measures might work, what measures, like including curative treatment, might work, what forms of life-sustaining treatments would work, and where should we really incorporate palliative care into their care package, really needs iteration on these illness trajectories. So to start with cancer, if you would look at this red line, so this is the point where the patient is being diagnosed with cancer. And then there is a very gradual decline as the patient goes through diagnosis, all the investigations, initial forms of treatment. And then there comes a point where the patient is diagnosed with metastasis, and all the paraneoplastic effects are coming into play, where the patient's functional status. So actually I couldn't tell you, like, this is the patient's health status or the functional status. So it rapidly declines at this point and then progressively leads to death. So in terms of cancer, because we have done extensive research on the illness trajectories of different forms of cancer, we really know better about the prognosis of these patients. So a patient with small cell lung cancer who had merely 3 months of prognosis after diagnosis versus a patient diagnosed with prostatic cancer where the survival rates would be much higher. Likewise, we tend to know more about the prognosis of patients with different forms of cancer. And then moving on to the second forms of illnesses, they are organ failures, including chronic obstructive pulmonary disease and chronic kidney disease. So these patients are being diagnosed at a point where there is already a deterioration of their the organ function to some extent. So this is the point of diagnosis, and this is where their functional status is to start with. And then there is a gradual decline in the functional status, and you may see these dips, these troughs in between. So these are the acute exacerbations that occur. So acute on chronic kidney failure, or acute exacerbations of COPD. So during these times, the patient's functional status drops suddenly, and with or without treatments of curative intent, the patient's functional status comes back not to the previous limit, but to a functional level that is slightly below the previous level. So likewise, there can be different distinct exacerbations occurring along the course of the disease, and ultimately a patient is unable to survive yet another exacerbation, and then patient suddenly dies. So looking at the prognostication, it is quite difficult here. Why is that? So the patient could have died earlier during the previous exacerbations. The patient, if where the patient was not really cared for during the third exacerbation, the patient might end up dying here rather than here. So the prognosis is really hard to predict in these patients. Then we move on to the final illness trajectory that we are going to look at. So that is the patients with cognitive failure, such as those with forms of dementia, and the patients with frailty. So they have actually, again, they have deteriorated to some extent when they start, when we diagnose that the patient to have frailty or dementia, and they have a very fluctuating course that is progressively declining towards death. So the prognostication wise, this could be better predictable than organ failure, but could be worse than cancer because they also can deteriorate at some point, and they are at a very low functional level to start with when we diagnose. So they can proceed towards death at any of these along the course, any of these points along the course. So knowing about these illness trajectories is very important when we treat patients with life-limiting illnesses. And then we look at what a symptom burden is. We know that these patients have different symptoms. Some of they may be physical symptoms, psychological symptoms, social symptoms, and even spiritual symptoms. So these are not just symptoms, but forms of suffering. So that is why we call them symptom burden. How do these symptoms burden the patients and even their families? For instance, the psychological, social, and spiritual forms of um, symptoms may not only burden the patients, but they will invariably affect the loved ones, the family members. So, and the context of definitions, you have to be broadening your, you have to be transcending your forms of thought about individual symptoms. So this is just an example. So you would have come across this definition of pain while you studied physiology. So this is the anesthesiology definition. Pain is an unpleasant emotional or even physical experience that is associated with actual or potential tissue damage or described in such terms. But that is a valid definition, but that is looking from the perspective of the pathogenesis of pain. But in palliative care, we are looking the pain from a patient's perspective. So in palliative care, simply pain is what the patient says it is. If the patient says that he has pain, yes, the patient has pain. And what it is like, and the patient is the only person who is able to describe what pain is like. So, so here we are looking at at each of these symptoms from the patient's perspective, and how do these symptoms burden the patients. So in these boxes, you can see how prevalent are these symptoms among patients with life-limiting illnesses. So the physical symptoms that are among the commonest symptoms are lack of energy, pain, and lack of appetite. Psychological symptoms being feeling drowsy, difficulty concentrating, feeling sad. And they have social concerns, feeling that people do not understand what you want, burden on family members, lack of support from the loved ones. And even there can be legal concerns that can be included into the social forms of suffering. And then spiritual aspects, thoughts about death and dying, spiritual needs not being met. And what happens after death? Where do we go? And, what sort of a life or what sort of a existence will I have after death? And is, the deeds I have had during my lifetime, are they going to affect me during afterlife? So all these concerns are affecting these patients. We have to be very sensitive about all these elements as we care for these patients. It is not just the patient appearing at your door, at your clinic, and then you assess what the physical symptoms are, you are addressing them and sending the patient home. It's not the approach here. And do palliative care physicians or palliative care clinicians have to deal with emergencies? Oh yes, there can be many emergencies affecting patients with life-limiting illnesses. So management of these can be a different lecture on its own right, but the patient can have choking due to obstruction of airway. They can have hypoglycemia, especially those with diabetes and multimorbidity, medicinal opioid overuse, superior vena cava obstruction due to thrombosis, spinal cord compression, commonly due to the collapse of metastasized vertebra, hypercalcemia, which is the commonest metabolic emergency among cancer patients, and then hemorrhage, acute severe pain, overwhelming psychological distress. So all these can be presenting as emergencies. And even in the primary care level, as general practitioners, we need to be able to address these and do necessary referrals to hire specialized palliative care centers should the need be. So the personnel involved with palliative care provision. So whose job is it to deliver palliative care? Is it the doctor's job? No, the evidence has really proven that teamwork and only teamwork is going to help these patients and their families, facing life-limiting illnesses. So, who are these team members? I have only very arbitrarily, divided these health professionals to be dealing with physical, psychosocial, and spiritual aspects, but interchangeably, these clinicians are supposed to look at all different domains of palliative care. So, for instance, I have listed the doctors and nurses among those, in charge of the patient's physical aspects, physical concerns, but they also need to deal with social, spiritual, and psychological aspects, depending on their level of expertise on those areas. So, looking at the doctors who are involved in the team, general practitioner, I have listed the general practitioner there because that could be the person who initially diagnoses the life-limiting illness, and then although the patient is being referred to the disease-specific specialists such as oncologists, cardiologists, the general practitioner coordinates care between the specialist forms of care in the hospital or even specialist palliative care physicians in the hospital settings, and even the community resources, the clergy, or even the spiritual caregivers. So the general practitioner plays the role of the care coordinator. While being in the community, the general practitioner knows in and out about the patient's social background, what forms of support the patient has at home, and what forms of community resources the social environment has in that context. So he's well aware about the resources and is better able to coordinate between care resources. So that is why I positioned him right at the beginning. But then, equally or more important are the contributions of disease-specific specialists, as we discussed, pain specialists, interventional radiologists, and palliative care physicians. So the list continues. So these are only a few sorts of doctors involved with palliative care provision. And the nurses, there are community nurses, registered nurses who work in hospices and hospitals. And there are other allied health professionals besides nurses, like physical therapists, including physiotherapists, occupational and speech therapists. Then we also, must not forget that there are evidence-based forms of alternative and complementary therapies that can help palliative care patients. So there are alternative therapists involved in delivering these therapies. For instance, art therapists, music therapists, relaxation and reflexology therapists, massage therapists, acupuncture and acupressure therapists, aromatherapists, and the list continues. So you must also have a fair understanding about the role of these alternative therapists. They have their own peer-reviewed journals with publications arising from very good quality research that have been of proven benefit in helping palliative care patients. For instance, So this is just a kind of an example I may use. So there are patients with cancer who are suffering from intractable nausea and vomiting that are not, responding well to the pharmacological therapies that you administer. Then we can seek the help of an acupuncturist. There is an acupuncture point in the wrist called the P6 acupuncture point, where you can administer acupuncture therapy, and it has proven to be of benefit, symptomatic benefit to the patient. So there have been controlled trials to show that this form of therapy is effective on the patients. And alternatively, you can also apply TENS, or what you call a transcutaneous electrical nerve stimulation on the same P6 acupuncture point. And so this can be done by even non-acupuncture therapists who are not expert, who do not have the expertise for acupuncture, but just apply the probes over the wrist and administer TENS therapy. So why it is important? Sometimes these alternative therapies might be more acceptable for the patients than the medication therapies that we as allopathic clinicians have to administer. So that is what we can offer, but some form of Ayurvedic therapy might be acceptable for the patient. And if it is evidence-based, then you might consider let the patient go forward and get those forms of medicine. And then if it is not evidence-based, be it allopathic medicine, be it other forms of medicine, you also have to safeguard your patients against falling prey for these non-evidence-based therapies, which can be really harmful. And then pharmacists also play a role in dispensing opioids and other medications. And they also make sure those medications are available in the clinical settings that you practice. In some countries, there are community pharmacists who are working in community settings and running pharmacies, who are also able to advise. Even in Sri Lanka, we have pharmacologists now who are in a better position to advise about the medications, drug interactions that can happen when we administer medications. So their help is really invaluable. Okay, so this is a publication by the WHO. I have put it here to show how important it is to to emphasize the role of a general practitioner and other primary healthcare professionals in the delivery of palliative care. So WHO has integrated palliative care among the domains of primary healthcare, as I described earlier. And there is a WHO guide for the planners, implementers, and managers published. So there are some interrelated publications alongside this that emphasize the role of general practitioners and other primary healthcare professionals in delivering palliative care in community and home-based settings. And this is to show you the role of a music therapist. So why have I included music therapists among those who are helping with the patient's physical symptoms? So it is a form of distraction, so that a patient who is sensitive to music, when we administer music therapy, his mind will move away from the forms of suffering, be it pain or even existential suffering. So existential suffering is another term where we use to describe the patients who are, who feel themselves to be suffering just because they are living a very poor quality life. So, the patients with any form of suffering can be helped with music therapy if they are sensitive to that form of therapy. So same applies for art therapy and other forms of alternative therapies. So, and this is some interesting point here. I initially thought, singing and playing instruments for patients is what music therapy is all about. And it is when I conducted a clinical trial on passive music listening intervention for cancer patients and how it affected their perceptions of pain, only then I learned that music therapy isn't just administering music to patients. It is involving them in production of music. They might not be experts, but you involve the patient in composing music. So in this case, in this picture, you can see the little guy. He is playing the drum while the music therapist is playing the guitar. And at the next moment, the therapist might even pass the guitar to the kid and allow him to play the guitar. Yeah. So not to the tune, but it's a form of stimulation that is helping the patient psychologically as well as while helping the patient alleviate symptoms through distraction. And then moving on to the psychological aspects, there can be doctors or psychiatrists who can attend to the psychological aspects, and then there are psychologists who are trained social experts or even sociologists who are trained on psychology. So in addition to that, all healthcare professionals involved must also take care of patients' psychological aspects to the level of expertise they have. And now moving on to social aspects, I would start with family members. So they are also part of the team. So we also care for them, but they also help us in managing the patient, to care for the patient. And then there are social workers, home carers, and in other countries, they also have community volunteers helping with the patient's daily routines or even provide them food. There's a thing called Meals on Wheels, or even just go and have a chat with these patients who are living by themselves in their households. We have a lot of young people in other countries, volunteering to care for these patients. So if the patient has poor activities of daily living, instrumental activities of daily living, these volunteers may even help with those tasks. Spiritual aspects of care. This is something that is very important, yet neglected in many care settings, especially the hospitals where the time pressures are more for the clinicians so that they don't have time to attend to the spiritual concerns of the patients. And sometimes they are also not geared, or they do not have the expertise to touch the basic aspects of spiritual needs of the patients. Yet this is very important when the patient declines progressively towards death. The concerns about death and dying and what happens after death, they all strike the patient and also the family members. So which is why we need to ask if they will not even come up with these problems, we might have to ask and identify spiritual forms of distress and try to alleviate them. When providing spiritual care, as clinicians, we might not have all the expertise we need to go into depths about the spiritual concerns. So rather than trying to press the patients with our forms of ideologies about religions and all that, it is more important to just listen to the patients. So that is quite proven. When we are not experts, it is important that we don't preach the patients on what spirituality is, but rather listen to them. And when we do not have the expertise, we have to be humble enough to refer the patients to those who have the expertise. If the patient has subscribed to a certain religion, the religious priests could be consulted, or even the patient could be referred to religious priests, or the religious priests could be summoned to the bedsides of the patient if the patient is in the terminal phase, so that they can have a discussion, or they can chant Pirit, or to engage in do religious sermons that could help the patients. But on the other hand, there could be patients who do not follow a particular religious faith. Maybe they are more knowledgeable about all the religions, but they have not subscribed to a particular religion. In such instances, it is important to know that religiosity and spirituality might have quite an overlap. They are quite distinct things, quite distinct concepts. So while a patient might not be religious, that person might be very spiritual. That person might have their own understanding about death, dying, what happens after death, what are the good virtues to live by. So they might have their own forms of understandings. So which is why some other countries have multi-faith hospice chaplains or pastoral caregivers who do not preach about a particular religion, but they identify the spiritual strength within the patients and try to reinforce that spiritual kind of understanding within them, than even trying to contradict with them. So spiritual care is a very important element in palliative care. And then we might also need to involve lawyers. So even in other lectures, we might see how lawyers come into play. And then in clinical decision making, especially in hospital settings, some countries have the room to engage clinical ethicists. They also have ethics rounds where they discuss complicated cases about patients that they see in ward rounds. They are called ethical case deliberations. So they are the people with more sociology background. So there are an array of other professionals that can help in delivering palliative care. And what are the models of palliative care delivery? We discussed earlier that only team approaches are helpful in the delivery of palliative care. But how should these teams be organized? So this was an exploration that I did with another UK academic, and we came up with these models to show what palliative care models would be like, the teamwork around palliative care be like. So towards the leftmost end, you can see what multidisciplinary care is like. So this is multidisciplinary care. The patient is right at the center in all of these models. Sorry. And so these are what individual professionals do in terms of caring for these patients. So these individual professionals have a very clearly defined role to play in palliative care delivery. For instance, this is the physician. This one is the physician. And he has only got to care about the patient's physical aspects. And this is where the nurse is located. And she has a very defined forms of care towards the patient. And this is the spiritual caregiver. And that individual, that professional has a very set defined tasks to fulfill while he or she cares for the patient. So there is no overlap between their duties. It is very clearly defined. So in that instance, there can be slight care gaps as well. Because if it is a team that only comprises a physician, a nurse, and a physiotherapist, so they only have very defined roles, and there is no spiritual caregiver, so that aspect of care will be neglected in this model of care. And then if we move to the rightmost end, we have the transdisciplinary care model, where there we have a few professionals involved with the care of the patient, and the physician has his role, the nurse has his or her role, and there are care gaps. But when this initial team works on a shift, and when the shift expires, they transfer this care to a new physician, new nurse, new physiotherapist, and so on. So they have very clearly defined roles, which are non-overlapping. And one physician transfers the care to the other physician, one nurse to the other, but there are significant care gaps, if you can see. And what we are now advocating in palliative care is towards this interdisciplinary care model, where, well, here is the physician, and here is the nurse, and here is another professional. So they have overlapping care, duties of care towards the patient. So the physician takes care of the physical symptoms and prescribes drugs. And as a psychiatrist, he also attends to the psychological aspects of the patient, but also looks at the patient's spiritual care needs, also looks at the patient's social care needs. And when looking at the nurse might also care for the patient's, basic hygiene. Patient looks at the patient's nutrition and all that, but she also looks at the patient's social care needs and spiritual care needs. So there is a significant overlap between the duties of care of these professionals. So there are minimal chances for care gaps. So the patient is receiving holistic care through this approach, in comparison to the multidisciplinary approach, and the transdisciplinary approach. You may read more on our paper. It is named Team Approaches in Palliative Care. So you may refer to that paper for more information. Then where can palliative care be delivered? So the palliative care services are organized around hospitals, hospices, and in the patient's home. So that is community-based palliative care. So hospital-based palliative care is, as the name implies, it is limited to the hospitals. But there are instances where hospital-based teams also do community services. So there are hospital-based outpatient clinics and hospital-based palliative care units that do ward rounds. And then there are hospital-based palliative care specialists, nursing specialists, medical specialists, and so on. And there are hospices. We will come to the concept of hospice later on, or else the patient can be cared for in home settings. But there can be also overlap between these care models, as you can see in the picture below. So there can be hospices, and there can be overlap with hospital-based palliative care, where in the hospital premises, a hospice could be located. And the hospital teams may be visiting patients in their households, home care teams. And they can also have outpatient services, and there can be daycare centers, and so on. And they have a significant overlap in terms of service organization. So the hospital-based palliative care, and example is the palliative care unit in the Apeksha Hospital. Initially, it started mostly with volunteers. I also had an opportunity to volunteer there. There was a once a week palliative care clinic for outpatients, but even the patients who were receiving inpatient care in the hospital were referred to this clinic to address their more intractable symptoms. And now this is there is a pain specialist, not a palliative specialist, but an anesthetist who is a pain specialist running this palliative care unit with the help of oncologists and nurses, nutritionists, social workers, and so on. And another example is the palliative care unit that was established in the teaching hospital Karapitia, and I had the privilege of conducting some staff training in this institution. It looks more like a resort than a part of the hospital. So one of the leading oncosurgeons there has been able to draw funds towards developing this huge project, a very inspiring project actually. You can see these are the images of this building, and the rooms are like hotel resort rooms with attached bathrooms, with disabled, with special adaptations for disabled people. This is now being run as one of the wards of the hospital, staffed by nurses and doctors. And then hospices. So some of the examples are the Shant Sevana Hospital, which is right opposite the entrance of the Apeksha Hospital, Maharagama. And then there is again very close by is the recently established Sahana Sevana Hospice, which is a project by the Palliative Care Association of Sri Lanka. And then there are other hospices located around Sri Lanka, in Hangwella and in Jayewardenepura, dedicated to either cancer patients or patients with chronic kidney disease. and so on. So they are providing a homely environment for the patients. They are staffed minimally. Sometimes they don't have an in-house doctor. They have nursing staff and attendants and caregivers, but no in-house doctors. But the doctors are only consulted when there is a need. And they provide a calm but stimulating environment for the patients to lead parts of their lives. So that might not be the terminal phase. That it can be only a phase of the patient's life that is spent in the hospice. The founding idea about a hospice is this is a place where the patient would go and die. So it was kind of, it was kind of stigmatized in the UK and even in Korea and in other countries where hospices were first established. But now hospices are having different goals of care. Some of them provide respite care for the caregivers and families when they need a break from caring for the patients, because they are also going through extreme amount of distress caring for these patients, so they need a break. And so for that period, the patient might be moved to a hospice. And then another example is the Sahana 7 hospice that I talked to you about earlier, which is located in Maharagama. So that is where, when that institution provides care for the patients after they are being discharged from the hospital, and before being transferred home, these patients and their family members receive some form of training how these patients can be cared for at home, about stoma care, about wound care, how to take care of the catheters and NG tubes. So the family members are being trained in this institution before they are being sent home. And hospices typically do not have intensive forms of treatment. So no chemotherapy, no sophisticated forms of radiotherapy, no life-sustaining treatments, no ventilators. So usually the norm is that the patient signs an agreement that I would not demand for these forms of intensive therapies while I'm admitted in the hospice. So the goals of care are made clearer at the point of admitting the patient into a hospice facility. And then finally, I would say about the home-based palliative care and community-based palliative care. This is a point where the general practitioners are playing a major role. And we are at the moment in the process of developing a postgraduate diploma program for general practitioners on generalist or primary palliative care, which they can deliver in the community. So while the patients can be brought to the general practitioners' clinics, the GPs could also do home visits to care for these patients who are poorly, mobilized. And then even the outpatient departments are being visited by patients with life-limiting illnesses in seek of palliative care. So this is another aspect that I would like to touch on, but this will be a broader lecture on its own. A frequent problem that we encounter with patients with life-limiting illnesses is that while they, as they progress with their illnesses, they tend to deteriorate mentally. There is a physical deterioration, and alongside there is a mental deterioration. So their mental capacity or the ability to engage in healthcare decision making for themselves is declining as they proceed with their illnesses. So there we need to have a form of established pathway to have their forms of ideas secured, so that we can, as clinicians, make decisions more confidently in the future when the patient loses mental capacity, right? So are you with me there? So you can read more about this. Basically, the thing that you need to read is about advanced care planning, not advanced care planning. That is a very frequent misnomer. It is advanced care planning. Advanced is that you do something preemptively. So you are doing something in anticipation of the patient's mental capacity loss. You are doing something in advance. You are doing this to ensure the patient's autonomy, to extend the patient's autonomy beyond the point that patient loses mental capacity. So when the patient loses mental capacity, you cannot be asking the patient whether, would you like to be attached to a ventilator now? Because your lungs are failing, we want you to be attached to a ventilator. Do you like that or not? So so that is kind of an ethical question, but the patient is not able to answer. So you have to make those discussions early on and have a better idea about the patient's way of thinking. So the advanced care planning has different forms of implementation. One is advanced directives. They are also called living wills in some countries. So advanced care directives are legal forms of documentations where the patients document their preferences for especially life-sustaining treatments such as cardiopulmonary resuscitation or ventilators, artificial nutrition and hydration that would sustain the patient's life without giving a survival benefit. So the patient documents his or her preferences on a document, gets a lawyer to sign that document. So in some countries it is legally binding for the clinicians to follow the patient's wishes. So, but this is a very broad area. This is not a one-off document. It has to be revised as the patient proceeds in the illness, and it has its own limitations. And in the Sri Lankan context, we also have legal limitations to have advanced directives. So everything needs to be streamlined. The clinical guidance, the legal backing for that, and then the formulation of advanced directives. So everything needs to be formalized. So we are aiming to do that in the near future. And besides these legal documentations, something that we can have is to have just, even in the bedhead ticket or in the patient's clinic record, we write down the patient's preferences and wishes for his or her future health care. So when the patient loses the mental capacity, we can make use of those documentations to access and to look back at the patient's preferences and base our decisions on those factors. And then another form of it, another form of another part of advanced care planning is appointment of surrogates for decision making. So the surrogates are, there are 6 different forms of surrogates, but a legally appointed surrogate is one that has been documented in the Advanced Care Directive. A person who is familiar with the patient's likes and dislikes, wishes, preferences, values, and all that. So this person is a substitute decision maker or a surrogate decision maker for the patient. So we can appoint a surrogate decision maker legally, or what we frequently have in Sri Lanka are default surrogates. We do not have legal means of appointing a surrogate, but we usually have default surrogates. Okay, so this elderly woman is having a breast cancer, and she does not have the capacity, the mental capacity to decide on the ventilatory support. So we summon the patient's elder son to make the decision on the patient's behalf. So that is a default surrogate. But in other countries, there are legal means to appoint a surrogate that the patient, him or herself, appoints based on his or her preference. Based on his or her preference. So that is through a document called the lasting power of attorney. So there are different forms of lasting power of attorneys, and I will not go into details there. And then there is another concept called independent mental capacity advocate, and that is for unbefriended patients. That is something in place in the UK for the patients who do not have the next of kin, who do not have relatives to decide for them. So I will not go into depths about that concept here. And before we and now I would specifically like to emphasize what the real cornerstone of palliative care is. What do you think it is? So, ethical decision making. The emphasis on clinical ethics is really big in palliative care. So even if you would go through the literature, they will be tremendous. So ethical decision making is not easy. And the only thing is that in the Sri Lankan clinical settings, we consider less and less about the ethical imperatives of clinical decision making. If you really dive into it, it will be really a complex process. There is not just one thing to consider, but so many things. But then our main aim of palliative care is to achieve better quality of life for the patient and the families, which is why we need to be ethical in our decisions. So this would be a huge a lecture on its own, with maybe discussion of ethical case deliberations to be discussing about ethical decision making. So in summary, palliative care is all about making people faced with life-threatening illnesses happier along with their family members. And there are so many ways that you can make them happy and reinstate the hope that they have lost. So you might need to broaden your knowledge on palliative care and what does it have to offer as we go to be able to help better the patients. So the principal dimensions of assessment and treatment are physical, psychological, social, and spiritual aspects. So ethics are integral, as we just discussed, and of them, patient autonomy is the most salient thing, where we, make clinical decisions to align with the patient's preferences. So the patient should have a role to play in these clinical decisions. And then this is an interdisciplinary clinical discipline where collaborative work between professionals with maintenance of mutual respect is essential. And then palliative care can be provided in hospital, hospice, or home-based settings or in the community. And finally, I would ask you to do some additional reading. So that is how you develop knowledge. So pain and symptom management as you do your clinical appointments and when you have your other lectures, pharmacology lectures, you will get to know about managing the symptoms. But communication skills is something that is really important to improve on when you deliver palliative care, and in generally as a clinician you have to be very confident with evidence-based communication, because communication is also therapeutic in especially in palliative care. Then you have to learn a great extent on ethics. For you to be practicing as clinicians, the little amount of ethics that is being taught in the medical undergraduate curriculum is not good enough. I can say that confidently. If you are not very keen on reading about ethics, you better just type ethics and palliative care on YouTube and you will come across a wealth of informative videos how to make ethics-based clinical decisions. And then understand the indications and ethical conduct of palliative care sedation if you are interested. And then there are, out of interest, you can also read about euthanasia and physician-assisted suicide, although they are not legal in Sri Lanka. And a good reading source I would suggest you is Introducing Palliative Care. This is not correct, not introduction, Introducing Palliative Care by Professor Robert Twycross. That is very concise, easy to read, simple book. Go for it. And if you have questions, you may email through my official email ID, or I have developed a palliative care module on Google Classroom. You can alternatively post your questions there so that the answers will also be available to your colleagues who have enrolled for that module as well. And thank you, and good luck with your studies, and I would sincerely wish you would develop your knowledge on palliative care, and I also hope to upload some other important aspects of palliative care onto the YouTube channel. Cheers.